Good morning. My name is Henry Walk, and I'm the Incident Manager for the CDC Zika response. It's my pleasure to introduce our CDC Director, Dr. Brenda Fitzgerald. Dr. Fitzgerald brings to CDC a state public health perspective, as she served both as the Commissioner of the Georgia Department of Public Health and as the State Health Officer. She also brings a clinical perspective as someone who served as a practicing obstetrician gynecologist for 3 decades. Welcome, Dr. Fitzgerald.
Thank you so much, and thank you so much, everyone, for being in the room. I apologize for not being there in person. I am in D.C. Because of Harvey. But I cannot tell you how important I think this work is, and I cannot tell you how much I appreciate all of you being in the room. As you all know, Zika is the first time in 50 years that we have had a virus that's associated with a birth defect. And as that new entity, there are a lot of things that we know we have to do and a lot of things that we know we do not know. And that's the reason for bringing the public and private partnership together because it's now time to move on to the next phase of our understanding about Zika. The important thing is that we know already in the United States that there are over 2,000 pregnant women who have lab evidence of Zika, and of those 2,000, there are 93 infants born with known birth defects. In the territories, especially Puerto Rico, there are almost 4,500 pregnant women with evidence of Zika, and of them, we know that 128 have obvious birth defects at birth. But we also know at this point that the microcephaly is terrible, but it is not the only birth defect that may be evidence with a Zika infection. We now know that Zika virus attacks nerve tissue particularly, and we know that there are cases of blindness and deafness or problems associated with the optic nerve and with the nerve tissue associated with hearing that have been affected, a significant number. My concern, quite frankly, is that we know that there is tremendous brain development, early brain development that's occurring in this very crucial part of a child's life. So our concern, and my particular concern, and I know concern of a lot of you in the room, is what is this going to do for normal neurologic development of children? At this point, of course, the testing has picked up these children, but we do not know if there are some women, especially in Puerto Rico, who may not have been tested because there's widespread evidence of the mosquito that carries Zika in the island, and there are about 30,000 live births a year. We know that, again, about 3,000 of them their mothers have evidence of Zika infection, but not all the women have been tested, and some of those that were tested may have not been in an ideal time for the testing. So we have a huge clinical need ahead of us. What we have asked you here today for 2 reasons. One, to help us come up with some schedule and some thought about what is the best way to monitor these infants. We certainly are committed to having a Zika pregnancy registry, and we certainly want to be open and continue the dialogue between the physicians who will now be caring for these babies and the people that have done their original testing to see if any other very obvious defects occur. So it really requires us to activate as a private community to figure out how often we need to be monitoring these babies, and also if there are other things that we need to be monitoring. We also are concerned particularly with Puerto Rico because of the large number of babies there, and certainly Dr. Walk can tell you about, he's recently gone to Puerto Rico, can tell you about the on-site activities there, and certainly the medical community there stands ready to work with all of us to make sure that those babies are cared for, but we predict that it will be an overwhelming task. I believe we're up for it. and I especially believe that we are up for it if we get together at this early time and have thoughtful planning and thoughtful ideas about how to evaluate when new evidence emerges. I'm particularly happy to introduce as the next person to speak to you Dr. Karen Remley. Dr. Karen Remley is a pediatrician by trade. She has been the state health officer of Virginia, so she certainly understands the public health arena, and she is currently the executive director and CEO of the American Academy of Pediatrics. And we know that her leadership will be a tremendous asset as we all try to do the best thing for these babies that may have been exposed. So, Dr. Remley, we'd love to hear your comments.
Thank you very much. It's particularly fun to follow Dr. Fitzgerald because we've been good friends for years. So I think, as everybody in the room knows, whatever we do, relationships and thoughtful, trusted, and caring relationships are what always make the biggest difference for children and for our communities. I apologize. I'm not with you. I'm actually have a daughter getting married in 2 days, so as soon as I finish this phone call, I'm heading to St. Louis to be the mother of the bride. So it's nice to have something wonderful to celebrate. And it is hard for me to believe it's been a year since you all got together and developed guidance for caring for pregnant women and infants with Zika, and how much we've learned and how much we still, as Dr. Fitzgerald said, the gaps in knowledge of what we had. It has been, I have to say, I know that there are a large number. As I look through the list of attendees, I see many incredible researchers and clinicians and friends and members of the Academy, and it is just a privilege to be able to speak to all of you today. I wanted to share briefly some of the activities the Academy has been involved in over the last year. We have Project Echo Zika, which is a telementoring program connecting AAP experts, many of whom are around the room, with clinicians in Puerto Rico, American Samoa, and the U.S. Virgin Islands, knowing that some of the specialties that are needed are scant in those communities, and to be able to connect in that way, clinician to clinician. I think I would say that the people who are doing the telementoring are learning just as much from those very capable and astute clinicians on the ground. We've been doing educational outreach, which is particularly focused on parental psychosocial support videos that are being done in both English and Spanish, resources for parents, a webinar series, and websites, and then also support for our chapters, particularly in those parts of the country that may be most likely to see Zika cases. And then last, we've been doing support for the CDC local health department, Zika field assignees in those affected areas, connecting our chapters with those local health departments and making sure that, again, those relationships develop. That's just a few highlights of the work we've done. I wanted to also particularly recognize the incredible partnerships and integration of work that have occurred in Puerto Rico. I know Drs. Valencia, De La Vega, and Yasern are there. I've had the opportunity to know Dr. Yasern very well. I've heard wonderful things from about Dr. Valencia and Dr. De La Vega, and I just am humbled by the way you have shown leadership in this important health issue for all of our children in the future. I know there's also many ACOG leaders there, and I think, once again, this demonstrates the incredible commitment that ACOG and AAP have to women and children, which are our future. And the last thing I will say is, as Brenda said, I have the advantage, as she did, of being able to be a state health official and understand that it is crucial that not only do clinicians and researchers partner with public health, but that we have mutual respect and we fully integrate the work we do, because it is the clinician at the bedside who is truly the most trusted source of information. And that's true whether it's Dr. Yasern taking care of a patient in Puerto Rico or Dr. Kimberlin taking care of a patient in Alabama. It is that doctor-patient family relationship that is really going to help us with this. And I stand ready to hear from Fan and everyone else how the day went. And I'm excited that some of the work you're going to be doing will be very Zika-focused, but may help push us even farther in terms of how we look at innovative ways to screen children, regardless of whether it's from a Zika infection or from other causes, to make sure we have early identification of problems. And with that, I'll turn it back over, I think, to you, Henry. And Brenda, have a good day in Washington and advocate for all those people in Texas.
I absolutely will. Thank you so much, Dr. Remley.
Thank you.
Great. Thanks to both of you. So next, I want to introduce Dr. Christopher Zahn. Dr. Zahn represents the American College of Obstetricians and Gynecologists as their Vice President of Practice Activities. He's been a critical leader and partner to CDC during the Zika response. So welcome, Dr. Zahn.
Well, thanks, Henry. Thanks to Dr. Fitzgerald and everyone at the CDC for inviting us to participate in this, and certainly also to be here with the partners in this with AAP. ACOG has clearly worked with AAP, the CDC, Society for Maternal-Fetal Medicine, in addressing this crisis ever since early 2016. And I think importantly, although probably not a great reason for it, but Zika has really propelled maternal and child health to the forefront of health issues around the nation, so really drawing attention to that. I think it's been an amazing relationship in working with the CDC as well as AAP and SFM in addressing this. We've been on calls sometimes several times a week with folks at the CDC, and it's really been incredibly important in developing that partnership to put the recommendations out there, particularly done so in an anticipatory and a proactive manner as opposed to reactive. So it's really bi-directional, where the CDC provides us with information that we can build into our practice advisories to get the message out to the obstetric providers, but it also provides a way for us as clinicians to get the message back to the CDC, particularly from folks in our recently formed Zika expert work group. Several of the members are in the room today to really look at what are the practical aspects, what are the implementation challenges of these recommendations. And I think some of the examples of the most recent communication, even surrounding testing of asymptomatic women in the most recent updated guidance, really demonstrated that ability to talk about those challenges before the guidance is released as opposed to afterwards and then scrambling to figure out what to do. As mentioned, probably our biggest collaboration is in the development of the practice advisory. The practice advisories were developed a couple of years ago as a way to have information out there relatively quickly until we were able to come out with more established guidance. The practice advisory has been updated 10 times since January 2016, so it just reflects how rapidly things are changing. And it gets a lot of views. It's been viewed over 160,000 times since it was initially published. It's translated into Spanish for those folks who can benefit from that information. So again, it's a key way for us to try to get the message out to the providers as well as for the implementation piece. As Karen mentioned, we've worked closely with the AAP. In fact, we're working with the AAP on several activities, including a toolkits that have been distributed to over 35,000 of our members twice, and it's been incredibly well received. We're in the preparation of a survey to look at what people know and, more importantly, what they don't know about Zika, what are some of the challenges in clinical practice, and what tools they need, what resources they need to help better inform the providers such that they can take care of the patients, which is this conference, this forum is critically important to inform that process as well. We've also been working with the CDC's local health department initiative and connecting our ACOG district and section folks at the local level with those local health departments, because it's really the boots on the ground at that point, and that's where the true implementation of these guidelines are in effect. So what can we do to help with that? And then finally, we also, Zika Care Connect, we think is a critically important resource to try to make the members available. So when they do have those questions, they have a place to go to answer some of those questions. And I think this collaboration really emphasizes an important point, is this is just the most recent example of a significant health challenge, particularly one that's impacting women and even more so pregnant women. But we don't have to think that long ago about Ebola, H1N1, and it's Zika today, and it'll be something else tomorrow. And at some degree, I think it's fair to say that all of us in the room, whatever organization we're representing, have had to scramble. Whenever these emerging issues come up, things get dropped, people have to drop what they're doing, and it's got to be a rush to get this done. And ideally, based on this progression, and again, there's going to be more in the future, ideally we could have resources better structured, better prepared, better ready to go, so we can mobilize more quickly, thoroughly, and efficiently, as opposed to having to reinvent the wheel every time something comes up. So hopefully we can all learn a lesson from this exercise as well as some of the past ones to be able to take that on. So again, it's been an amazing collaboration. We very much appreciate the opportunity to be here, so looking forward to the next 2 days. Thank you.
Okay, so good morning again, and I'm Henry Walk, the incident manager for the CDC Zika response, and I just wanted to thank our partners, the American College of Obstetrics and Gynecology, American Academy of Pediatrics, and of course our director, Brenda Fitzgerald, for joining us in this important discussion, and thanks all of you for joining us today. We're now in the 586th day of activation for the Zika response. It's really an unprecedented engagement of thousands of CDC staff. The countless more federal, state, and local staff have worked alongside of us, and our coordination with HRSA and CMS has been especially essential to the provision of services to Zika virus-affected individuals, especially pregnant mothers in the U.S. and the territories. And we're very happy that HRSA and CMS colleagues are here today. Throughout this response, CDC has relied upon all of its partners to ensure up-to-date guidance is disseminated, and that our experts get practical feedback from practitioners on the ground, such as you, so we can improve the work that we do. This response has brought together diverse groups, such as pediatricians engaging with emergency preparedness specialists, and policy advisors working alongside epidemiologists and vector-borne or vector control practitioners. This cooperation with you and within CDC across multiple centers has helped ensure their efforts were coordinated, and that when we made big decisions, we heard multiple perspectives. You've heard Dr. Fitzgerald talk about the magnitude of the epidemic. More than 42,000 symptomatic cases of Zika virus infection have been reported, and more than 6,500 cases in pregnant women. Certainly there's been a decline, and Dr. Fisher, I'm sure, will talk more about this, a decline in the number of new reported Zika cases in 2017. However, we're still in mosquito season, and it's difficult to predict when and where local transmission or outbreaks will occur. This week, I'm very happy to announce that the CDC's Emergency Operations Center has transitioned from a level 2 to a level 3 response. Level 3 is the lowest level of our Emergency Operations Center's activation. So it goes level 1, level 2, and then level 3. And after level 3 is deactivation. As the cases continue to decline, CDC is in the processing of transitioning staff and important activities back to their home offices and programs. A decrease in activation level does not mean that people are no longer at risk from a Zika virus infection. Zika virus continues to be a public health threat in the U.S. and abroad, and CDC continues to support efforts to protect pregnant women and their babies. There's still much to learn about Zika virus. I certainly have learned a lot in the past few months, for sure. CDC and its partners are working to improve diagnostic capacity, develop better tools to prevent infection, and understand the full range of potential outcomes in babies with congenital Zika infection. Babies will continue to be born with congenital Zika infection in 2017 and beyond, underscoring the need to stay committed to following these infants and ensuring care. I think this slide illustrates a useful way to think about the follow-up care of infants potentially affected by Zika virus. At the top of the pyramid, there are a small number of infants with Zika virus-associated birth defects, about 250 in the U.S. states and territories. In the middle tier, there are infants born to women with laboratory evidence of possible Zika virus infection. These are infants without birth defects, and there are about 5,000 infants in the U.S. states and territories. On the bottom tier, there are infants with congenital exposure to Zika virus without any laboratory evidence. There are many more of these infants. In Puerto Rico alone, where there was a high level of Zika virus transmission, there are about 30,000 live births a year. We're following these infants in the top two tiers through the Zika pregnancy and infant registries, and we have published guidance on the evaluation and management of these infants. For the bottom tier of infants, we have questions about the appropriate follow-up of these infants, questions we hope to discuss with you in the next couple of days. So this forum is incredibly important to us to continue and advance our understanding of the clinical care of pregnant women and newborns. Thank you all again for joining us here in Atlanta this week to lead these discussions and learn from our colleagues all together. CDC cannot do the work we do without your collaboration and support. Thank you. So you're going to see a lot of me today. So I'm pleased now to introduce Dr. Dana Meany-Delman, co-lead of the CDC Zika Pregnancy and Birth Defects Task Force. Dana is an obstetrician gynecologist and who has served in the Zika response from the beginning since January of 2016. She will outline the goals and objectives for this forum and help set the stage for what we hope to accomplish in the next 2 days. Welcome.
So welcome. Again, good morning. A lot of friendly faces. I'm very excited to see folks that I've known or that I've gotten to know over the phone over the past 20 months. So really excited that we've all come together. A sincere thank you to Dr. Fitzgerald, Dr. Remley, Dr. Zahn, and Dr. Walk for their opening remarks. I want to acknowledge and thank our colleagues from ACOG and AAP for all their collaboration and dedication to the Zika response these past 20 months. And as co-hosts of this forum, we are grateful for their help as we identified all of you and as we all come together. We are honored to have such a wonderful and diverse group of nationally recognized experts here with us. Thank you all for traveling to Atlanta. We realize that many of you have had to cancel your clinical or your professional obligations and have left your families to be here with us. And we recognize that traveling during a hurricane response may be particularly challenging. Our thoughts and prayers go out to those who've been affected by Hurricane Harvey. As Dr. Fitzgerald mentioned, the Zika response has demonstrated how important it is for the clinical and public health communities to partner during emergency responses, and together we have a lot to be proud of. We have undoubtedly impacted the lives of pregnant women and families throughout the U.S. and throughout the world, and we may never know how many cases of congenital Zika virus infection we have prevented. We have invited all of you to this forum for these main objectives. First, to ask that you share your individual expertise and experience with Zika. Your input will greatly assist CDC as we consider potential future updates to our guidance for infants with congenital Zika virus exposure. Second, to help us review the data that has emerged since our last pediatric meeting in July of 2016. And third, we are hoping to work together to identify strategies to enhance communication and coordination of care for Zika, but also for other conditions that affect pregnant women and infants. And we think we will all learn a lot from each other in the next 2 days. So briefly, I'd like to outline the plan for today. This morning, we'll have a series of talks to ensure we're all starting from the same page. We will have presentations in our initial session that cover Zika virus epidemiology, diagnostic testing, our existing recommendations, and the emerging evidence. We will also hear from Dr. Miguel Valencia, our close collaborator in Puerto Rico, and he will describe how Puerto Rico has actively sought to increase access to services for families affected by Zika. This afternoon, we will divide into pre-assigned topic sessions as shown on this slide and in your agenda. We have done our best to pre-assign experts in a balanced manner to these pre-assigned topic sessions, and we also are mindful of space constraints. If you don't remember what session you're in, you should have a little colored dot on your name tag that can serve as a reminder. At the end of the day, we'll reconvene in this room to briefly present themes from concurrent topic sessions. This will provide an opportunity for others who are not part of a given topic session to provide individual expert feedback. What will happen after the forum? CDC and colleagues will compile the individual input from our experts here today. And this input will help CDC as they develop potential future updates for guidance. We hope to have a draft updated guidance document within the next 6 to 8 weeks before the Zika response deactivates, as you heard from Dr. Walk. And our plan would be to acknowledge all of those who participated in the forum in future clinical guidance updates. Now for some logistics. For those participating by webcast, so this morning's session is webcast, if you have questions or comments, please send them to the email address listed here. And please include your name and professional affiliation. And we will respond to questions over the next several days. For media questions, please email media@cdc.gov. We are pleased to have Paul Decknick. Can you stand up, Paul? From Deloitte Consulting. He will be here to help us facilitate our discussions and, most importantly, to keep us on time so we can get to lunch. He will also help to remind us to focus on the forum objectives and to avoid groupthink. This forum is not about achieving consensus. It is for us to hear about the pros and cons, advantages and disadvantages of any future changes to the existing recommendations. And lastly, please remember to disclose any new competing interests. You all filled out a form for competing interests, but if any new competing interests have arisen, please let us know. And please make sure you identify yourself when speaking. We all want to know who you are. We all want to get to know one another. For CDC participants, we have invited experts all over the US, and we want to hear from them. So please be gracious hosts to our guests, and let's hear from them. For our non-CDC forum attendees, there are some housekeeping details. There's a form in your folder that goes through these, but there are some I must say. First, you're considered visitors to the CDC campus, so you'll need to be escorted between buildings. You don't need to be escorted to the bathroom. We do have a large number of designated escorts. These are people who are relatively new to CDC and would love to hear your experience. So as they're escorting you, please feel free to engage in conversation with them. These are folks who are very excited to talk with you. All visitors must enter and exit through the security desk that you came through in the visitor center, so please don't come out through other ways. And everyone at CDC must wear a badge that you've all received in plain sight. And when you are moving from building to building, the green topic session, you will need to have your government ID. Please bring your name tags with you if you are moving from room to room, and please bring them home with you tonight and back with you tomorrow. Restrooms are located down here to the left. They'll be pretty easy to find. An escort can help you if you need assistance. In case of an emergency, an escort will direct you to the appropriate assembly area on campus. And then finally, picture taking on campus is not allowed outside of CDC buildings, and specifically not on the 3rd floor in Building 21, which houses the Emergency Operations Center. Sorry, those were a lot of logistics. There's more in that page, in your folder. So now I have the pleasure and honor to introduce Dr. Mark Fisher, who will provide an overview of Zika virus epidemiology. Dr. Fisher is a medical epidemiologist and pediatrician with CDC's Arboviral Diseases branch, and during CDC's Zika response, he has served as a lead of the epidemiologic task force. Welcome, Dr. Fisher.
Good morning. Thank you, Dr. Meany-Delman. As Dr. Meany-Delman said, I'm going to give a brief overview of the Zika virus epidemiology. So in May 2015, the first locally acquired cases in the Americas were reported in Brazil. And as of August 2017, local mosquito-borne transmission has been reported in 48 countries or territories in the Americas. The only countries without reported local transmission in the Americas are Bermuda, Canada, Chile, and Uruguay. This table shows numbers of suspected and confirmed Zika virus disease cases reported by country or territory in the Americas from 2015 through 2017. A few important points. So suspected cases are generally defined as cases with clinically compatible illness. They may vary by specific country, although PAHO has a specific definition of specific symptoms for suspected cases. Confirmed cases are suspected cases that have some laboratory evidence of disease. As noted in the first column, overall 48 countries from the region have reported locally transmitted cases. Overall, about a little over 787,000 or almost 788,000 cases have been reported over this time period. And as you can see at the bottom in the footnote, about a third of those cases have some laboratory evidence of disease. So there may be cases suspected that are actually due to other causes, and certainly there are underreports of cases. By country, you can see that by far the most cases have been reported from Brazil, with over 350,000 cases, making up about 45% of the total, followed by Colombia with 108,000. Those two countries together make up almost 2/3 of all the cases reported. This shows an epidemiologic curve of the suspected and confirmed cases reported to PAHO from the entire region. Couple of important caveats here as well. So first, I'd like you to note the y-axis, which has a total of 40,000 cases, and that will change in some of the other slides I show. The x-axis shows cases by week for 2015 through 2017. It's important to note that Brazil did not make Zika virus reportable until 2016, so they did not start reporting cases as Zika virus until that time. In addition, the cases here are per the date they were reported, not the date that they necessarily occurred, so there's a shift in the epicurve. But overall, as you can see, as far as reported cases, there was a substantial peak of cases in early to mid-2016, which then decreased over time through 2016, and then has a small peak again in 2017, but at a much lower level than the previous years. You can also see by region, and there's a color error there for South America, but the vast majority of cases have been reported, as we saw from South America, notably Brazil and Colombia, followed by Central America and the Caribbean. This now shows the epicurve for Brazil alone, which, as you can see, really mirrors the cases for the region. The y-axis now is 25,000 cases, and as you can see, there's an abrupt reporting starting 2016. As we know, there was a large epidemic of Zika virus in 2015, and that's where it was first recognized. Many of those cases were initially reported as dengue, and then cases were reported as Zika virus starting in 2016, and some of those cases, again, will be reflected from previous years. But you can see, again, a peak in early 2016, then a dramatic decrease as you move to the middle of the year, and then a small increase again in early 2017. I want to contrast that to show that there are still some areas that are having Zika virus activity in 2017, albeit at much lower levels. So this shows suspected and confirmed cases reported from Ecuador for the same period of time. And as you can see now, the y-axis is 1,000 cases, so substantially lower than the two previous epicurves that I've shown. But what I wanted to show is that Ecuador had a small peak with upwards of 300 reported suspected and confirmed cases in mid to early 2016, then a decrease at the end of the year, but have then seen an increase similar to their peak in 2016 in early and mid 2017. And then similarly, I wanted to show Peru, which gives an example of another country in epicurve. This also has a y-axis level of 1,000 at the top. Peru had very few reported cases in 2015-16, but then started having outbreaks reported in late 2016 and had their peak upwards of 800 or so suspected cases reported in early 2017. So there are still small focal areas in the Americas that have reported outbreaks or sporadic cases of Zika virus in 2017. Moving on to the United States, from 2007 to 2014, there were 14 Zika virus disease cases identified in U.S. travelers. These were people returning from parts of Asia and the Western Pacific that had sporadic or outbreaks of disease. However, following the introduction and spread in the Americas, cases among U.S. travelers increased substantially, as you might predict. And then in 2016, there was limited local mosquito-borne transmission identified in 2 states, Florida and Texas. And in 2016, large outbreaks occurred in 3 U.S. territories, Puerto Rico, the U.S. Virgin Islands, and American Samoa. This shows the number of Zika virus disease cases, so these are all symptomatic disease cases, as well as presumptive viremic blood donors, so those are persons who donated blood and were identified through the screening. These are all laboratory confirmed, so unlike for PAHO reports, these will have some laboratory evidence, and these will be reported based on their date of onset, not the date of report. So in 2016, there were a total of a little over 41,000 disease cases reported from the United States, with 5,102 of those being from U.S. states and over 36,000 of those being from U.S. territories. By contrast, in 2017, there's been a total of 770 cases reported as of last week, 215 of those being reported from U.S. states and 555 from the U.S. territories. The bottom part of the table shows presumptive viremic blood donors identified through the routine screening of the blood supply. And as you can see, the numbers are substantially smaller but reflect the same trend. So in 2016, there were overall 359 blood donors reported, 37 of them from U.S. states and 322 from the territories. In 2017, as of last week, there were 12 positive blood donors, 9 reported from U.S. states and 3 reported from territories. And I want to point out the footnote there, which is important, that these cases do not include congenital disease cases, so these are postnatally acquired Zika virus infections. So as far as breaking down the laboratory confirmed Zika virus disease cases reported from U.S. states and the District of Columbia for 2016 and 17, 2016, as we saw, there were a little over 5,100 cases. The vast majority, 95% of those, were reported as travelers to other areas, mostly areas in the Americas. In addition, there were 224 locally acquired cases presumed to be through local transmission, 218 of those from Florida and 6 from Texas. And then there are a few cases reported from other routes of infection, which includes sexual transmission, 1 case of laboratory transmission, and 1 case of an unknown likely person-to-person route. In contrast, in 2017, the 215 cases reported thus far, 213 of those have been in travelers. There have been no locally acquired cases reported thus far from U.S. states, and 2 sexually transmitted cases have been reported. This shows the cases from the U.S. states and District of Columbia reported by month of disease onset, with the y-axis being 2,000 here, which you'll see again a contrast with the territories. The main point again is we see a peak in the reports of cases of both travel-associated and local transmission in mid-2016, with a sharp decline by the end of the year and a small number of cases reported as of this year. The locally transmitted cases are shown in yellow. It shows a breakdown of those cases by states of residence, and overall you see about 22% of the cases, this is travel-associated or local transmission, were reported from Florida, and 20% from New York, 8% from California, 6% from Texas. So again, about 50 to 60% of the cases are reported from those 4 largest states. Shows a breakdown of the cases reported from U.S. states and District of Columbia by sex, and you can see 2/3 of the cases are reported among women. This is likely somewhat due to surveillance and testing bias, testing and identification of pregnant women or women of reproductive age. It's unclear whether sexual transmission plays a role in addition to this difference, but in general, probably more a surveillance testing bias. And this shows a breakdown of these same cases by 10-year age groups, again from states and District of Columbia, with a peak between 20 and 49 years of age, which primarily reflects both the age of travelers predominantly, and as well surveillance bias, where we look for cases and testing of pregnant women and persons of reproductive age. Finally, this slide shows the numbers of possible Zika virus infections reported to the U.S. Zika Pregnancy Registry from states and District of Columbia from 2015 through August 8th of this year, and these numbers were already referred to. But among pregnant women, there have been 2,100, a little over 2,100 possible Zika virus infections among pregnant women reported to the Pregnancy Registry. Been 93 live births of infants with birth defects and 8 pregnancy losses with birth defects reported to the registry. I'm going to show a series of slides, basically the same slides, but for U.S. territories. So these are laboratory confirmed cases of symptomatic Zika virus disease, non-congenital, reported from U.S. territories. As we saw in 2016, there were over 36,000 cases reported. Less than 1% were among travelers, and the vast majority, almost 36,000, were reported as locally acquired, presumed local mosquito-borne transmission. There are no cases reported among other routes, but in endemic areas, it's really not possible to separate out the possibility of, for example, sexual transmission from local mosquito-borne transmission. Contrast in 2017, as we saw, there are 555 cases reported. All of those are reported as local mosquito-borne transmission. This shows the month of illness onset again, and you can see the y-axis is now 10,000, so 5 times higher the y-axis maximum that I showed for the states, but it shows the same pattern. That is a peak in the number of cases reported by month in July and August of 2016, with a dramatic decline in the fall and winter of 2016. And as we saw, there have been cases reported in 2017, but just because of the scale of the curve, you can't note them on this particular slide. Shows a breakdown of those disease cases by territory of residence. You can see that overall, the 97% of those cases reported have been from Puerto Rico. 1,000 cases, or 3%, from the U.S. Virgin Islands, and 168 from American Samoa. Shows the breakdown by sex, which again is similar or very close to the same for states, and that is 62% of the cases reported from the U.S. territories were among women. And this shows the age group breakdown for U.S. territories, which is a little different. So here you have endemic transmission in these areas among a naive population without previous immunity. So you could see a broader distribution across all age groups, although you still see a peak among the 20 to 39-year-olds, probably again reflecting somewhat testing and surveillance bias among persons of reproductive age, however also possibly representing exposure. You can see about 10% of the cases were reported among children less than 10 years of age. And then this shows the numbers of pregnant women and live-born births reported to the Zika registry, the U.S. Zika registry with possible Zika virus infections. Among pregnant women, there were 4,418 possible Zika virus infections reported to the registry from U.S. territories. Live-born infants with birth defects, there are 128, and pregnancy losses with birth defects, there are 7. So in conclusion and summary, Zika virus, we've seen large outbreaks in the Americas that peaked in 2016 and have substantially decreased in activity in 2017. However, smaller outbreaks and sporadic disease continues to occur, some focal areas of some countries, and we showed Ecuador and Peru as 2 examples of that. The incidence and disease risk among U.S. travelers has basically followed the epidemiology of the outbreaks in the Americas due to travelers going to those areas, and a similar decrease over time in Puerto Rico and U.S. Virgin Islands. And the U.S. territories have markedly decreased their incidence in 2017, but continue to have sporadic infections that are reported. Thank you very much. Next, I'd like to introduce Dr. Wendy Cunard, who will provide an overview of Zika virus laboratory diagnostics. Dr. Cunard is the co-lead of the CDC Zika Lab Task Force and has helped lead the development of CDC's laboratory testing guidance for Zika virus. Please welcome Dr. Cunard.
So thank you, Mark, for that introduction. Good morning, all, and thank you for coming. For my presentation, as mentioned, I will be focusing on summarizing the limitations of the current Zika testing. This information is applicable to all of the existing assays and is not limited to the assays that are manufactured by CDC. So objectives for my portion of the talk today are to first provide an overview of Zika testing in general. I'd then like to look at the limitations of both the nucleic acid testing as well as the Zika serologic testing. I'd like to look at some additional challenges to a definitive Zika diagnosis, some limitations of infant testing, Then I'd like to move on to looking at this season, the bigger picture, looking at some of our emerging data and how this again will impact the results of our tests. And then finally, a changing disease prevalence and how we start to look at our assays in that light. Of note, some of this information is provided within the healthcare provider fact sheets that are associated with the FDA documentation for all of our assays. And for the two CDC assays, the Zika macrolisa and the trioplex, we have placed some copies of these fact sheets on the resource table outside. So before I move on to the specifics of the assays, I did want to provide an overview of testing so that we're all starting with the same information. It is important to understand that at this time, none of the Zika tests are FDA cleared. There is a large number of tests that are currently approved for emergency use, and more currently are underway and under review with the FDA. At this time, there are 14 nucleic acid tests and 3 serologic assays that have been cleared. This FDA process for emergency use authorization is intended to strengthen the nation's public health response during an emergency, and thus is far less stringent compared to the routine 510(k) process for most diagnostic assays. This abbreviated process allows the FDA to approve of the use of uncleared medical products for use in an emergency to diagnose, treat, or prevent serious disease. This is meant to happen when there are no adequate approved alternatives. For all Zika tests, timing of the testing is critical for optimal assay performance. Samples should be collected at optimal times following infection or exposure. Additionally, optimal assay performance requires close attention to the populations to make sure that they meet Zika clinical and epidemiologic criteria for testing. Intended use is another important aspect of laboratory testing in general. For the Zika serologic assays, all existing performance data has been based on symptomatic cases. Without data on asymptomatic screening, we are more cautious in our interpretation of these results. So as pointed out in my last slide, timing of testing is critical. Here I would like to look more at the markers of infection and how they can impact test results depending on when the samples were collected. This diagram shows an example of an IgM response following symptom onset. We know that IgM starts to come up soon after infection. However, this graph is only a representation of the timing of infection and is not definitive. Additionally, IgM duration, while shown on this graph to end at approximately 3 months, is not well defined and can vary within individuals. This graph shows how for symptomatic cases, it is much easier to see how timing of the testing can be targeted. For the asymptomatic testing, this is obviously a much larger challenge. Since the timing of infection is impossible to determine for an asymptomatic patient, there is a much higher chance of specimen collection falling outside of the expected duration of IgM detectability. Additionally, with the decrease in IgM levels, as we can see tailing off months after infection, the results or the tests and the IgM levels may linger within the equivocal zone for a longer period of time, which also creates a challenging interpretation. Next, I'd like to talk specifically about the testing limitations of nucleic acid performance. As mentioned previously, timing of the test is critical to diagnosis. Zika RNA is only detectable during the acute phase of infection. While we have seen some reports of longer duration within pregnant women, generally it is only detectable for about 2 weeks following infection. Data on asymptomatic patients is unknown. Another limitation is the potential for false positives. In general, these assays are designed to minimize the occurrence of false positives. These design elements for the nucleic acid tests include limited cross-reactivity as well as well-defined cutoffs and assay validation processes. However, contamination within the laboratory or elsewhere during the specimen life cycle is possible. False negatives are another potential assay challenge. A negative result does not rule out infection, as the sample may have been collected when viral RNA was not present, or potentially the test was used on samples such as amniotic fluid for which the assay has not been validated. As stated previously, viral RNA is only present for a limited duration in time. Overall, I would like to stress that it is important to remember that the absence of laboratory evidence of Zika virus infection cannot definitively rule out infection with the Zika virus in persons with epidemiologic risk factors. Next, I'd like to focus on the serologic assays, and again, review some of the limitations of these serologic tests in ways that they might be different from nucleic acid tests. Serology assays are also not always able to provide a definitive answer, and results should be interpreted within the context of the assay limitations. However, a negative IgM test, if performed at the correct time in the setting of a negative nucleic acid test, does provide some reassurances of the absence of infection during the current pregnancy. Anti-IgM antibodies are not detectable immediately after symptom onset. Plus, duration is unknown, and the duration, as I said previously, can be inconsistent. Another challenge is that the current serologic assays are not able to distinguish between recent infection versus infection that occurred 6 or more months ago. I also want to mention the plaque neutralization test. This assay is included within our testing algorithm and is recommended to be used to confirm an initial IgM positive result. A negative PRNT, when performed during the recommended time frame, along with negative nucleic acid testing, does indicate no lab evidence of Zika virus infection. This assay measures neutralizing antibodies that can't be used to determine the timing of infection. An additional limitation of this PRNT is that it does not have value in some areas. The cross-reactivity issues that occur during PRNT analysis mean that it is not useful in regions with high levels of circulating flaviviruses such as Puerto Rico. Like nucleic acid tests, serologic assays also have the potential for false positives. Here we would like to emphasize that the positive or equivocal results are not definitive for diagnosis. False positives can occur due to closely related flavivirus infections, as well as non-specific reactivity that is unrelated to the infection. These cross-reactive antibodies make it difficult to identify which flavivirus is causing the current illness. Serology can also have false negatives like any other assay. Absence of lab evidence of infection can't definitively rule out infection if the patient has epidemiologic risk factors. A false negative, therefore, in an infant would result in cases that are missed. Overall, for Zika serology testing, it is recommended to be conducted soon after symptom onset, but within 12 weeks post-infection in order to ensure the best results. Other challenges exist and can hamper efforts to obtain a definitive laboratory diagnostic result for Zika. As stated before, the Zika MAC ELISA is approved for emergency use only. The data provided for this approval and contained within the assay's instructions for use are actually quite limited. In an ongoing effort to improve this assay, we have looked at how the selection of either a negative control or the negative calibrator can affect the assay's performance. We have found that even when calibrators are used that are within the parameters of the EUA performance, that results can be impacted. This slide shows how when two laboratories chose different calibrators with different optical density ranges, that the final results of these tests were different. Here we show that Laboratory 1 has a calibrator that actually runs higher within the approved EUA range. And as you can see on the far right, they have ended up with fewer number of positives. Here we see that that lab has 31 positives within this collection of samples. The other lab chose a lower calibrator and actually has almost double the number of positives, or actually more than double. And here shown, we can see that this lab has a total number of 70 positives. This emphasizes the need to evaluate assay performance with well-characterized samples. The laboratory with the higher number of positives has achieved an assay that is performing with higher sensitivity compared to the other lab. And as shown from this table, the lab tests would vary based on a simple selection of calibration material and points to the need for a well-characterized gold standard as well as confirmation of the initial result. As mentioned, CDC is continually evaluating the performance of our own assays as we learn more about the virus. This slide provides an overview of our current efforts to standardize the CDC Zika MAC ELISA. We have, as part of this effort, developed a 3-phase plan to improve both the precision and the accuracy of the assay. Phase 1, which was completed in August, included the distribution of additional quality control guidance for both primary or plate acceptance criteria and secondary or clinical sample acceptance criteria. Phase 2, which we are targeting for completion in October of this year, includes the evaluation and distribution of a calibration control serum as well as a negative control serum. And as pointed out in the last slide, these reagents are key reagents that contribute to assay precision. This process will include a fully updated emergency use authorization submission to the FDA as well as updated instructions for use. Finally, Phase 3, which we hope to complete by the end of calendar year 2017, will include the manufacturing and distribution of a completely new Zika MAC ELISA kit. We will submit to FDA a new packet for EUA approval, and obviously this kit will require full validation prior to manufacture and distribution. So while testing in general can present diagnostic challenges, maternal and infant testing has some issues, specific issues that are worth mentioning. Passive transfer of maternal antibodies to the infant has the potential to complicate serologic test interpretation. IgM antibodies in general do not cross from mother to infant. This has not been well studied for Zika. Another potential complication is the lack of information on detection of maternal neutralizing antibodies within these infants born to Zika-positive mothers. Similar to Zika diagnosis overall, the role of nucleic acid testing in infants is not well characterized, and the duration of IgM and neutralizing antibodies is not well studied either. Finally, a positive Zika test in a placenta or a cord blood does not necessarily indicate congenital infection and could reflect maternal infection alone. Studies have reported that infants with clinical findings of possible congenital virus, but also have negative Zika virus testing. Some potential causes of this could be that the findings are due to infection by another cause. It could indicate that the testing, as we previously indicated, was either incomplete or not performed within the optimal time frame. It could indicate that the infant perhaps did not mount an IgM antibody response. And finally, it is also possible that a negative result can be due to the limitations of the test that is being used, as we have discussed here. Overall, as we look at this upcoming season, the emerging data has significant implications for Zika testing during pregnancy. This season has shown declining numbers of reported cases, and this situation results in a lower pre-test probability as well as a higher proportion of potential false positives. Along with the declining numbers, we have noted that IgM antibodies can persist for 6 months or more in some individuals. This prolonged response can make it difficult for healthcare providers to use Zika IgM results to determine whether an infection occurred during the current pregnancy versus prior to conception. This graph shows pregnant women with evidence of Zika infection in the U.S. territories. We are looking at this by date and test type. Here, it's a little more complicated in that we're looking at, in red, we see that this is showing the nucleic acid positive tests. The blue area is actually showing the IgM positives. So most of the infections, as we have seen in previous presentations, in 2016 were all identified through PCR testing, and you can see with the large increase in red within 2016. However, in 2017, what we noted is that the majority of infections were only positive with IgM, as you can see on the far right, the increase in blue. This larger proportion of IgM positive results versus the nucleic acid positives prompted us to review existing results and confirm initial testing. We believe that this increase in IgM positives is evidence that the IgM response has been prolonged in a time when very little virus was circulating. So again, looking at this new season, we have seen that infection prevalence is low, but here this slide shows how the positive predictive value of the test can actually change depending upon the prevalence of disease. This slide uses an example test that shows an assay with very high sensitivity and specificity. Both are shown at 98%. In a situation in which the disease is circulating and has a high prevalence, we can see that the positive predictive value of the test is also high at 94%. However, in a time when the disease prevalence falls, for example, looking at 1% disease prevalence, the positive predictive value of the test is actually quite low at 5%, and the false positive rate rises to approximately 95%. So in summary, even the best performing assays do not perform to the same standard when the prevalence of the disease is low. So in summary, I have provided, I hope, an overview of the current Zika assay limitations. We know that we still have knowledge gaps related to optimal infant testing, and this is information that we would use to document evidence of congenital Zika virus infection. I have also shown that as the outbreak has changed, we have looked at emerging data and found that this has required changes to the testing algorithms. This need was clearly demonstrated in our review of how disease prevalence can impact assay performance. And finally, CDC will continue to review our existing assays and look at ways to improve how they function within this changing outbreak landscape. Thank you.
Okay, so now's the time that we are hoping to have more discussion, maybe even raucous discussion. So let's have some questions and comments from the audience. And Dr. Fisher, if we can use the microphones, that would be helpful so that everyone can hear.
Hi, thank you. That was excellent. This is Rich Baggy from McGee Women's in Pittsburgh. I have a quick question about the lab testing. So that definitely was very thorough. It was definitely wonky, but so important. For other infectious diseases, a lot of the obstetricians that take care of those patients, I think, share the same experience where it seems to be a higher rate of false positive serologies from the pregnancy itself, such as we have a higher rate of HIV false positives, parvovirus, the list kind of goes on. So I wonder if that's been investigated separate from the false positive issue you have in the whole population. I'm wondering if pregnancy actually increases the false positivity rate by virtue of the pregnancy itself. And it seems that you may have the data to look into that, I suppose.
Okay, thank you. Thank you for the question. So I'm going to turn to Wendy or Mark. I know this is a tough question. I'm not sure how much data we have on this.
It's a very good question. I don't think we have data specifically to answer that for Zika virus, but as you point out, particularly with regard to serologic testing, there are antibodies, proteins made during pregnancy which can cause false positive results either in the pregnant woman or potentially in the infant through passive transfer, but I don't have a specific answer as to whether that occurs or to what degree with Zika virus.
Yeah.
Meg Fisher, no relation, from New Jersey, the Unterberg Children's Hospital. And actually my question, though, is for Mark. On our last ECHO call with American Samoa, they gave us their results. And interestingly, although they had a couple hundred pregnant women, they've had not a single affected baby. So the question then came up, is there an ethnicity or a racial difference in outcomes? And do we know this?
We do not. So for Zika virus, there are essentially two types of genotypes that circulate, primarily in Asian and African strains, and we've seen primarily Asian strains here, and that's what's circulating there. There have not been known differences by the virus itself, although obviously we have limited amounts of data, and there have not been, as of now, described differences in the phenotype or due to the population or ethnicity. So I think we're primarily talking about a numbers game because of the population that's under surveillance, but that's probably the best we can do right now. One other point, which I thought you might ask about for American Samoa, is it does bring up the issue of dengue. So American Samoa is having a dengue outbreak right now and has had dengue outbreaks in the past. And so that is an example of substantially complicating the diagnostic issue, because when they test people, they are seeing IgM antibodies, but those are really due to previous infection or passive continued IgM antibodies. They are not having any positive PCR results for Zika at this time.
Please.
Yes, hi, Ivan Gonzalez from University of Miami. It's just a comment because as a clinician and also the background of pediatric infectious diseases, I totally understand the false positive rate for the IgMs and the positive predictive value, especially in our area that we're having decreased numbers of positive Zika cases. However, I want to just kind of share with you something that we saw from before, where there was a woman that came from Venezuela, and if it wasn't because she was actually tested for IgM, the baby was born without microcephaly. And because of the IgM, it actually triggered the full workup on the baby. And that case was actually reported. Dr. Berkow, who's with us here today, she was the senior author that published it had all the findings. So the baby had calcifications in the brain and also had the hypopigmented lesion in the eyes. So I don't have an answer for you in terms of what we need to do, but I think that without having a screening tool that we can still use, is going to be very challenging because not all the cases are microcephalic. So we don't know when you would trigger a workup on all these babies. Thank you.
Thank you for the comment. Others?
Hello, Alberto de la Vega from Puerto Rico. With the last slide you showed regarding the positive predictive value and sensitivity with the huge drop we've had in cases, wouldn't that negate completely the use of these tests?
I think that's something that we have discussed, obviously, with the asymptomatic cases, and that's why, there is no longer the recommendation. I think that also goes to our lack of knowledge of how this assay performs in the asymptomatic population. But I think that that's part of what we continue to discuss, as an agency with, our external colleagues, because I think it is a challenging decision process.
It's David Kimberlin, University of Alabama, Birmingham. To follow on that, I found the last talk to be quite discouraging in terms of the performance characteristics or lack thereof. Can you just tell us, is this a good test, a bad test, a medium test? What is it? Give me some relation to other viruses or bacteria we test for.
So I think it's not I would never call it a bad test. I think if it was a bad test, we shouldn't have pursued an EUA. I think at the time, it was the best test we had, and I hope that we have documented a continued effort to improve the test. I think serologic testing in general is very different from nucleic acid tests, and I think it is not, as I've pointed out, it's just not as definitive. So I think we're improving, but I think it is a continued struggle with this decreased prevalence. I don't know, Mark, from the Fort Collins perspective, I don't know if you have anything to add.
No, I agree. I think the tests are good, but need to be used and interpreted carefully, as with any test. Similar to other things you test for, David, if you test for influenza rotavirus outside of the season, you don't get the performance characteristics that you might expect when you test for them when those outbreaks are occurring. And so particularly with serologic testing, I think we're dealing with the same issues of interpretation. We have some additional challenges with regard to the cross-reactivity that you don't necessarily have for other viruses. This is common to arboviruses and is not unique to Zika, but the challenges of where these are occurring, the level of Zika, dengue, other cross-reactive viruses makes the interpretation, particularly of serologic testing, challenging. The PCR, I think, performs as expected with any other PCR, but again, has the limitations of the epidemiology. When you're testing for it in an area where it's not occurring, you're going to have a majority of tests. Even though you have very high specificity, the majority of tests will be false positive.
Hi, I'm Debbie Levine from Boston. With all of the issues that arise with the serologic tests, and I know imaging will be a whole area that's looked at later, prenatal ultrasound is its own area, but neonatal head ultrasound is going to give you a huge amount of information, and it's an area that really hasn't been pursued well, especially if we look at asymptomatic infants who might have been exposed in utero. And I would just like to see data on a large population of these exposed, because there is a very specific finding that we don't see in other infections, and that's the calcification at the gray-white junction, and you can see that very easily with head ultrasound.
Thank you for the comment. Let's move. Yeah.
Lisa Hunter from Cincinnati Children's Hospital. I'm really wondering about surveillance efforts in the missing countries, in particular Mexico, where there's so much travel between Mexico and the U.S. Are there really no cases in the missing countries, or are there surveillance differences that need to be looked at or need to be investigated?
Thank you. Let me clarify that. So the slides that I showed just showed the largest, the table showed the countries with the largest numbers of cases reported. As mentioned, there are 48 countries, almost all of the countries and territories in the U.S. have reported cases. And then the individual country epi curves that I showed were just to give an example of the patterns. There absolutely have been cases reported from Mexico. There are some differences by country. So as an example, Mexico reports only laboratory confirmed cases, similar to the United States and Canada and a few other countries, whereas the other countries are reported the suspected plus confirmed cases, so they have cases without any laboratory testing or evidence of infection. Mexico, as an example, has a very good surveillance system for arboviral diseases, including dengue, chikungunya, and Zika, but the cases that are reported all have some laboratory evidence of disease.
I would just add to that we are following closely the cases in Mexico, especially along the border of Texas and New Mexico, Arizona, California, and to look for transmission patterns. And Texas certainly, for example, has heightened their surveillance along the border.
Hi, Bonnie Maldonado, Stanford University. So I was interested in, obviously we've been quite overwhelmed by the high degree of homology between Zika and dengue in particular. About 80%, I guess, homology between the genomes. And I guess my question is, how are you working with other laboratories, in particular NIH? I know Tony Fauci has been talking about trying to optimize his assays, and I imagine you are, but will we be talking a little bit more about this later, and what are the prospects for future testing capacities?
We are actively working with NIH. We were actually just up there a few weeks ago, and then a couple months ago they came and visited us. We actually have routine laboratory calls with them, and then there's other calls, from other aspects. So, we have been working with them. Most of the NIH studies are actually being performed with a version of the CDC MAC ELISA. They worked with some of the lab experts out in Fort Collins to develop that assay using very similar reagents. So a lot of the testing that they're doing is quite similar. But we totally agree, looking forward. I think from an assay diagnostic perspective, the other thing that we have done is, we did a broad agency announcement and put some funding out. So we do have some additional collaborators in addition to NIH outside of the agency we are also working closely with to look at future assays and diagnostics.
Flor Munoz from Baylor College of Medicine. Just had maybe a couple of quickly related questions. One is regarding that epidemiology, whether there are any other similar countries where you see an uptick this year compared to previous year other than Peru and Ecuador. And related to the dengue and other sensitivity issues with the assay, how do you assess for infant infection in that scenario when you have already potentially a lot of positive tests from the mother? So how do you differentiate maternal versus infant infection? And just last thing related to that, how do you assess prevalence when the majority of people are asymptomatic in the US in terms of just knowing what the infection rate is? Is it based on just the blood donor data that was shown, or is there any other way to assess true prevalence of infection in the US?
So in answer to your first question, I selected Peru and Ecuador to show because they're really the best examples of countries that have had similar or higher numbers of cases reported in 2017, although most of these were in early 2017. There are some other countries that have had increase in reports again in 17, but they are not at the levels that were reported from 16 or 15. So there may be some other countries out of the 48, but those are the two best examples that have reported focal outbreaks. And then I don't know if you want to address the other. Well, let me take, the prevalence question, I guess, and then I'll see. So, yeah, it's difficult to, for arboviral diseases in general, particularly flaviviruses and Zika in particular, to establish a prevalence of infection because of the cross-reactivity issues and some of the duration of antibody levels that Wendy spoke to. So the plaque reduction neutralization test, which measures predominantly IgG antibodies that neutralize, should be present for a very long time, if not lifelong. The problem is you can pick up low levels of cross-reacting antibodies to other flaviviruses. So if you measured that in a population of people who have been exposed to other flaviviruses, which could include dengue, West Nile virus as an example, or even have been vaccinated with a flavivirus vaccine, yellow fever, Japanese encephalitis, you will get you can see levels of antibodies, so it's difficult. A negative result, so if you have a negative PRNT for Zika virus, is very good evidence that the person has not been infected either recently or in the past with Zika virus infection. But because of that problem, it's difficult to do a prevalence study. There are antibody assays that are being developed that target different parts of the virus that may be more specific, and the hope is that those could potentially be used for prevalence type studies, but those still need a little further evaluation, in particular for the IgG component.
I think there was a third question about the maternal infant, sort of sorting through the.
Okay. The third question, Flora, that you asked was about distinguishing antibodies. So, IgM antibodies, as Wendy mentioned, and everyone knows here, typically do not cross the placenta. So typically if IgM antibodies are detected in a young neonate, we presume they were developed by the fetus in response to infection. As was brought up as far as problems in pregnancy, we don't really know whether there could be situations where the IgM could cross, unusual situations. Abruption or previa, for example, or potentially contamination. But in general, we believe IgM may reflect, the infant's antibodies. Neutralizing antibodies, or IgG, if such an assay was used, clearly reflect maternal antibodies and maternal infection, and those will decrease over time, as they do for other congenital infections, but we're not clear on the exact timing when those will decrease if the infant was not infected and it just reflects maternal infection. Presumably, though, after a period of time when maternal antibodies fall, say to 9, 12, 18 months, those antibodies would reflect fetal infection or congenital infection. One other caveat you do have, obviously, in endemic areas is they could reflect, postnatal infection. As we've seen, there have not, fortunately, been a lot of those, but certainly neonates or young infants are susceptible to infection. So right now, we're in a time period of very low infection rates, and so it would be unlikely to reflect that, but that's an issue over time, that in those areas, you'd have to always consider that.
Yeah, thank you. Ellen Lee from New York City. Thank you so much for those really informative presentations. This goes along the lines of all the lab questions. Would you be able to comment about Zika testing in the commercial sector? And specifically, I'm thinking about Diasorin, Zika IgM test, which has become available through some commercial labs.
So I can comment briefly. I think that, the Diasorin assay is a new assay on the market. It is the first NS1 targeted serology assay, so it does have a different target. Both the InBios and the CDC MAC ELISA target the envelope. We have done some preliminary assessment of that assay. Unfortunately, we do not have the platform at CDC, so we've had to rely on colleagues. What we have done is we have sent a panel of well-characterized samples to Diasorin, and we actually found that this panel in their hands performed very well and showed some, a high amount of equivalence to the CDC MAC ELISA, but also showed a very good sensitivity. It also showed a high specificity and did not show the cross-reactivity with dengue. That is one of the advantages of the NS1 target, is it doesn't seem to have the same cross-reactivity. We are also working with 3 public health labs, and they are doing sort of a retrospective analysis of between 100 and 150 samples, some positives, some negatives, and some other, potentially cross-reacting viruses. Again, that information has shown a low cross-reactivity or none with dengue. We have seen some cross-reactivity with hepatitis C, but I actually think that was acknowledged within the Diasorin package insert. Unfortunately, we don't have the data yet. We're working through some IRB issues with the public health labs, but that's still coming. I think that overall, some of our challenges, and I guess to speak to the question of commercial labs in general, is that not all of these samples really follow the true case definition. I think that, that most of, or maybe not most, but a high percentage of these samples may not be samples that the public health lab would accept. So I think we are actively working with the commercial labs, and in fact, I have a call with them later this week to discuss how we can better enforce some specimen criteria on these collections, because I think that does contribute to some of these potential false positives that we have seen from the commercial labs. Is that?
Yes, thank you. Thanks.
Thanks. Meg Fisher again, and this, I'm getting clearer on the serology, but I still have, obviously normally we would say, well, just measure the IgG. If the IgM doesn't work, we'll just follow up with the IgG, and I know there's the Flavy reaction and original sin. Does IgA help? Has anyone looked at IgA? I mean, it seems like we need IgG against something else, the envelope, I don't know what, or some other kind of IgG, not neutralizing. There ought to be some way that we could get to this better.
This is not a new problem, although it's new to Zika. It's been an issue for flaviviruses for a very long time, and people have tried to solve it. Has not been solved. IgA has been looked at, I believe, in some limited degree, not by our laboratory. I don't know of that as being an answer yet, so I guess you're talking about along the lines of toxoplasmosis, some combination of IgA. That doesn't appear to be an answer. The NS1 or targeting of other parts of the virus that may be more specific is one of the possibilities that is being looked at. In addition to blocking antibodies, something that removes the cross-reactive is another approach that several labs are taking. But I think right now it still is the same challenge of balancing the type of test you're doing in the epidemiologic sort of setting and the timing of infection and the expected risk of infection at the time.